Hello, everybody. This is Professor Ghulam Siddiq. Today, I'm going to share with you a case of a 46 years old lady who had a BMI of 44 and her weight was 121 kgs. She was non-diabetic and hypertensive, while there was a history of GERD for which she was on PPIs on and off. We performed an ultrasound of her upper abdomen, which did not reveal any gallstones, and her liver was also essentially normal. An upper GI endoscopy performed revealed mild esophagitis. She was planned for laparoscopic Roux gastric bypass. Standard 5 ports technique was used. Initial laparoscopy revealed quite thin tendinous part of the diaphragm. Other than that, no abnormality was detected. A window was next created close to the lesser curvature of the stomach, and this was about 5 centimeters from the G junction on the lesser curvature side. For the window, we stay close to the lesser curvature between the left gastric vessels and the lesser curvature. The window into the lesser sac is then created. I routinely don't use any energy devices other than a hook cautery. The pouch is next created. A 60 millimeter horizontal load is used initially. For vertical transection, two more 60 millimeter loads are used. Once the pouch is created, posterior gastrotomy is performed. Previously, I used to measure total small bowel length in revision cases, but currently I do it even in primary procedures. This was a primary procedure, and we identified the ligament of Treitz. The small bowel was then measured in clockwise fashion. The target here was that we should have a BPLM of 90 centimeters. When 90 centimeters were reached, we anchored the jejunum to the omentum, as this is going to be the proposed site of transection of the small bowel. The remaining small bowel was then measured all the way up to the ileocecal junction. We know the jejunum is quite thick-walled as compared to the ileum. When the proximal part of the ileum was reached, we noticed some bile stand fluid. On exploration of the bowel, a rent was found close to the mesenteric border. Suction was used to decompress this part of the bowel. The rent was then closed using 3-0 Maxon suture in double layers in a horizontal fashion. Remaining small bowel was examined for any further iatrogenic injuries and was found to be perfectly normal. The total small bowel length from the DJ right up to the ileocecal junction was 580 centimeters. Once the measurement was completed and enterotomy was then performed at the antimesenteric part of the jejunum, and the jejunum was then brought up to the gastric pouch. A 3 centimeters gastrojejunostomy was then fashioned. I routinely place a stay suture at one end of the gastrojejunostomy and close the common opening with an absorbable barbed suture. The Roux limb is then measured, and in this particular case, we take it as 100 centimeters. Side to side jejunojejunostomy is then performed using a linear stapler. A 6 centimeter tan load is used here. The common defect of the jejunostomy is then closed with 3-0 maxon suture in horizontal fashion. I transect the omega loop at this stage about 1.5 to 2 centimeters from the lateral edge of the gastrojejunostomy. Leak test is performed at this stage. And once satisfactory, attention is focused on closure of the pseudo Peterson space. An additional suture in this particular case was placed at the level of the gastrojejunostomy, that was to prevent acute twist at this site, though I routinely don't do this. This patient did very well post-operatively, and on the first post-operative day, she was discharged home. Thanks for watching.